Hello, I am Adashi, Professor of Medical Science at Brown University and host of Medscape One-on-One. Joining me today is Dr. Elliott Fisher, the James W. Squires Professor at Dartmouth Medical School. A noted health policy expert, Dr. Fisher is also the Director of the Center for Population Health at the Dartmouth Institute for Health Policy and Clinical Practice. Welcome.
Wonderful to be here.
And so wonderful to have you at last.
It's great to be here.
One of the most talked about elements of the Affordable Care Act is, of course, the Accountable Care Organization, or ACO for short. Perhaps we can start with a definition. What is an ACO?
Well, an accountable care organization is a group of physicians, hospitals, perhaps other providers, who come together to take responsibility for the care of a defined population of patients. Mm-hmm. In turn, they will be allowed to be rewarded if they improve quality and if they slow the growth in spending. So it's a new model of care intended specifically to be flexible, so that the diverse settings within which physicians practice around the United States are able to start working together in ways that they have not been able to do before and with rewards that they have not been eligible for before.
What can you tell us about the origins of the ACO? Is there a particular parentage or provenance that our viewers might want to be informed about?
Sure. Well, the idea germinated early in the 1990s when we were trying to think about how could we encourage physicians, hospitals, perhaps nursing homes and others within communities to work together to better coordinate care for the populations they all serve. We recognize that fee-for-service medicine rewards us for each encounter, but doesn't really create ways of supporting our work together. And it actually started in a small community of Randolph, not more than 50 miles from here, Randolph, Vermont. Randolph, Vermont, where we realized that we knew the resident population of the town of Randolph. We could calculate how much it cost to take care of them this year. We could estimate what it would cost next year. And with some partnerships with private payers and with Medicare, we thought, gosh, if we can predict what it'll be next year, if we allow the physicians and hospital to work together to improve care, they would be able to capture a share of their savings. So that was the germ of the idea. It certainly looked back to health maintenance organizations and the integrated delivery systems like Kaiser or like Group Health Cooperative of Puget Sound that had been in place for years and years. But those systems comprise only about 10% of physician practice within the United States. Most physicians didn't want to work as employees of a large organization. And we were trying to look for models that might allow physicians in small office-based practices to be rewarded for coming together to better coordinate care.
If I were to encapsulate this and say increased quality, decreased cost, and population health, would I be capturing the entire essence of the concept, or is there something still missing?
You're certainly capturing the aim. You know, the aim is to create ways for physicians and others to work together to improve quality, to lower costs, thanks to improved quality,
yes,
and improve population health. So that's the aim. The challenge in American policy and in American practice was, so how can we do that? How can we create incentives and structures, new payment models that might allow us to foster collaboration among physicians who are currently in their offices working together with each other already, in fact, but not being rewarded for it?
As somebody who was involved with the crafting of the Affordable Care Act, can you share with our viewers some insights as to how did the incorporation of the ACO idea end up in the bill, and what kind of permutations, adjustments, revisions transpired in the process?
Well, the idea really started to germinate successfully at a meeting of the Medicare Payment Advisory Commission, which your viewers are probably familiar with. It's the major congressionally authorized body that recommends to Congress changes in Medicare.
Yes.
And what we did was present some findings from our own research here at Dartmouth to the commission. And what we showed was what most physicians know perfectly well. We tend to practice as natural networks of collaborating small office practices around one or maybe two hospitals. We refer to our colleagues who we've gotten to know. We showed to the results of the research to the commissioners' meeting and pointed out that, boy, most physicians practice in these naturally coherent networks. And we suggested that they consider a way of revising the Medicare payment program, and private payers perhaps as well, revising the payment program so that if the physicians in that group could demonstrably improve the care for their Medicare patients, they would capture a share of the savings that they received from those care improvements. And we know the opportunities for improvement. We don't do a very good job necessarily around the transitions of care from hospital to practice. There's no incentive that rewards us for making sure we communicate effectively among specialists and primary care physicians. So, and they actually seemed to like the idea. You know, at that meeting, the chairman of the commission, Glenn Hackbarth, said, "We need a better name than the one you've proposed, Elliott." And I won't even repeat the name. It was a horrible name. And he said, "How about we call them accountable organizations?" And I said, "I think we need a little care somewhere in there. How about we call them accountable care organizations?" And so part of this germination of the idea was at that point, MedPAC itself started working on the concept. The rest of the story was that when Mark McClellan left Medicare, left the Bush administration, he stepped down and we started to work together to say, how can we take this idea that would let physicians across the country who don't necessarily want to be employees of Kaiser come into a new model? And we worked quite closely with Congress, sharpening the idea, worked with the Medicare Payment Advisory Commission, worked with the AMA, worked with the hospital associations. How can we modify this germ of an idea to create something that we all might support? We worked with consumer groups as well.
So in a sense, the endorsement of MedPAC sounds like it had a great deal to do with the momentum that ultimately was acquired, although it also sounds as if significant legwork was still required with the various hospital associations, with Congress and the American Medical Association and the like. But the train was out of the station.
The idea had germinated.
Yes.
We started to write about it. We published a few articles. MedPAC had a chapter of one of its reports on ACOs. The next big step was we did some further modeling along with Dr. McClellan of how might this work financially for Medicare. The Congressional Budget Office, we worked quite closely telling them about the model. They actually did some calculations that then showed that their estimate was that this payment model would save money. Now, as soon as you're putting together legislation and Congress has all these spending rules, they can't spend more unless they save somewhere else. Once the Congressional Budget Office scored this proposal as saving the federal government a little money, not a lot, but suddenly everyone in Congress was much more willing to think about having this proposal included in the legislation. That was the second probable piece of the partnership.
Well, as we all recall, the Affordable Care Act now dates back to March of 2010. Almost 2 years later, I believe early next January, the final rules that regulate ACOs will take effect. What, in real terms, does this mean to the various parties that may have an interest in taking part in an ACO. What does January 3rd, 2012 in effect mean, or does it?
So there are a number of ACO programs that are underway under the federal legislation. But the national program, what's referred to technically as the Medicare Shared Savings Program, the final rules were released on October 20th of this year, and people will be able to begin applying for this new payment model starting in January.
So the whole process, shall we say, is actualized and kicked off.
The doors open.
Beginning January.
The doors open
Yes.
in January.
I see.
And so there will be an application process, and the key requirements are that a group of physicians or a physician in a hospital be able to define an organizational structure that can take accountability for a population of Medicare patients that's of sufficient size that we can measure measure the cost and quality of care for that
Yes.
population. So you have to have an organizational entity that can take responsibility. Enough primary care physicians in that entity who are caring for enough Medicare beneficiaries
Yes.
that we can identify who those beneficiaries are and be able now to track performance and estimate spending targets against which to calculate the savings. So that process of defining the eligible organizations has been done. It's not too arduous a process. Medicare was tremendously responsive to the comments that many made. These can be physician-led organizations, they can be hospital-led organizations, but they have to include representation from all parties. And there are special programs authorized to support physician-led organizations moving forward. Many physicians are quite nervous that this will be another grab by the hospitals, to run our lives. And there's special programs being put in place to provide capital up front to physician organizations that want to step forward and do this if they currently don't have enough resources to build the infrastructure to do it.
So as these ACOs are being formed, their constituencies are likely to include, but may not be limited to, physician associations or organizations of varying sizes, obviously hospitals or healthcare systems. Would community-based organizations be a party to some of these arrangements, and are we overlooking potential other parties?
I think there's a very strong openness to a variety of governance structures, as long as they include enough primary care physicians to make these things have a sufficient population size to manage the care of that population. It is not required that hospitals be members of these organizations.
Okay.
Many of the applicants are likely to be, physician networks, independent practice associations, or IPAs, or community-based collections of docs who've decided to come together to say, but the providers have to be part of it. There needs to be a strong community membership, consumer membership representation. If not formally so, then the organizations need to demonstrate their commitment to engaging consumer organizations. So these are intended to make care better in our communities and make it more affordable for our children.
So apart from the indispensability of providers in the mix, this sounds very much like an effort that to fly would be able to document that it can in fact care for a meaningful population of patients, and that the necessary resources, human and otherwise, are in fact at the table.
That's the critical piece of the application process. It will be convincing. For you to be eligible to participate in this program, you will have to convince Medicare in your application process that you have the capacity to do this, that you're willing to report on the performance measures that are required to track quality, that you have a sufficient population size, that you've thought about how you're going to do care transitions, so that how you're going to inform patients about what's going on for them. So you have to have a plan to do exactly what you suggested.
And maybe we have not emphasized as much as we should have the issue of coordination, although it obviously falls under the rubric of quality, but perhaps it deserves additional emphasis, care coordination.
It's very clear that the measures of quality that they will be relying on include both some measures that we would think of as technical quality. How are we doing on preventive services? For example, how are we doing in diabetic care? Many of the measures that we're used to from other physician quality measurement initiatives. But these also require surveys of patients who will be asked, were you able to get in to see the doctor when you wanted to?
So the quality of the experience.
The quality of the experience and of care transitions. Was care well coordinated? So this is a high priority for this very vulnerable population, patients with multiple chronic illnesses who do make transitions across settings of care.
It may not be an exaggeration to say that the ACO at its best will, we hope, implement some of the best features of American medicine as we would like to see it.
Well, I think there's a tremendous opportunity for us to step off the treadmill that so many physicians feel they're running on. It's probably better to think of a hamster wheel, that's turning, and they cut the fees, and you have to just run that much harder. The major aim of this is to figure out a way to support clinicians, physicians, nurses, others, in their capacity to deliver the best possible care through this new payment model. That, while not overly generous, because it puts some responsibility on us for savings, is very much intended to say, how can we create the best possible care for the patients we serve?
You alluded briefly earlier to some concern as to who might lead.
Mm-hmm.
From the point of view of the regulations, are there any expectations as to which party might be expected to lead, most appropriate to lead, or is that left wide open and will be decided in the review process of the various applications?
I think there is a recognition that to do the work requires real resources. It requires an investment. It requires putting in place electronic health records that can help us make sure we know where our patients are. It requires new governance models that create ways of creating new relationships among physicians and hospitals. It requires care management. How are we going to, it won't be the physician who's necessarily taking the complex, frail, elderly person and helping them manage the trajectory. It will be a nurse or a social worker. It's going to require resources to effectively transition from our current care models to the new care models that can really deliver on the potential of American medicine. Most physicians in small office practices don't have access to that kind of capital or resources. So there is legitimate concern on the part of smaller physician groups, smaller office practices and physicians that, of course, we're going to be vulnerable to hospitals who seem to have all the money in the current system. That said, Medicare has established this specific program I mentioned, the advanced payment model, and there are lots of private payers and shared service organizations who are trying to build the capacity to support physicians leading these initiatives. I think it's a very open question who will succeed in the long run. We know that if you look for the waste in American medicine, most of it's in the hospital sector. Our work at Dartmouth, I spent my first 20 years working on something called the Dartmouth Atlas of Healthcare. And we've shown dramatic variations in spending and quality across the United States and tremendous potential to achieve savings. Most of those savings will come from reducing avoidable hospitalizations. So physician leadership, physicians' willingness to step forward and say, we will make this model work, creates a great opportunity for them to capture those savings from the hospitals. I think there are many hospitals that are nervous that this model will be hard for them to be partners in. So And I look at, we've been working with a number of early ACO initiatives in Tucson, Arizona, and Southern California. And those are physician-led initiatives where physicians have majority control over the operations. One has a strong partnership with a hospital, but the other two that I'm most familiar with are purely physician-led, and they'll be choosing which hospitals they want to work with based on what kind of partnership and in care transitions, in care management and what kinds of services they can expect from the hospitals.
As one who is close to this evolving scene, is it your sense that integrated health centers, including perhaps academic health centers, are more likely to be involved, are more at the forefront of this movement? Or is that really an equal opportunity employer and you're seeing grassroots movement all over the place?
Academic medical centers will be quite challenged to succeed under this model. They've got some ways of practicing. They're just as tied to the fee-for-service system as everybody else is. And so as I look at the movement already, the 160-odd places that we recognize around the country are involved in these ACO initiatives. I think the vast majority of them are not academic medical centers. I think it's likely that the nimble, smaller initiatives, not tied to current academic promotion and ways and structures, may have an easier time demonstrating that this model can work. I have been really struck by watching our Tucson ACO, and it's a very the Southern Arizona Accountable Care Organization, very promising initiative.
In the near term, what would be your projections as to the number of Americans who would be enrolled in an ACO in the near term? And to the extent that you can project, and I realize this may be difficult, if we were to have this conversation a decade from now, and all your dreams were to come true, how many Americans might be cared for by an ACO?
A couple of things. First, we should remember Niels Bohr, who said prediction is really tough, especially about the future. So I'm glad you framed that around my hopes as opposed to my confident prediction. But in the near term, I think we'll have several hundred organizations caring for tens of thousands each. So, we can do the math. It won't be huge at the outset. It may grow rapidly. I think it's very important for us to recognize that there are two ideas at heart here. One idea is the notion that we will transition to more integrated systems, whether they're virtual or real, that are capable of managing patients' care over time. I hope that 100% of Americans are in organizations that are committed to taking good care of them wherever they are, not based on the patient's having to make a decision to drop in or find their doctor. So we need to make that transition. Whether you're on the right or the left of the political spectrum, the notion toward integrated, coordinated care is coming. And so if that's what you mean by accountable care, I'm hoping for 100% of that notion of accountable care. We want to be responsible for our patients. If you're saying the Medicare Shared Savings Program ACO contract with its 33 particular measures, I don't really care what the number is. This is about creating a path for physicians to move toward better ways of providing care.
Well, perhaps one way of thinking about the efforts currently underway under the leadership of the Centers for Medicare and Medicaid Services is as a catalyst for the movement you envision, which may have much broader implications and really deal, to re-emphasize what we may have underemphasized before, coordinated and in fact actively managed care was another term I think you used, which all seem to be long overdue.
Yeah, I think there's, I think Medicare is one catalyst, but every major health plan has multiple initiatives underway in their current payment models to test these new approaches. Whether it starts with episode payment, where you might be paid a single amount for a hip replacement over 90 days, that's very much about starting the conversation between hospitals and physicians around how you're going to coordinate care. The patient-centered medical home, the redesign of primary care practice, is very much about getting primary care physicians to be conscious of their responsibility and capable of managing care over time for a population of patients. I think that's where we're going. I mean, any physician who thinks fee-for-service medicine is going to continue without stress hasn't been reading the newspapers. We know fees are going to fall. They're probably going to fall further. If the SGR fix, the way of fixing the sustainable growth rate formula, that could make things even worse than they're predicted to be. We know Medicare fees are not going to keep up with medical inflation. They're going to be below medical inflation. These new payment models, whether bundled payments, ACOs, medical home, all offer physicians a way to start thinking about how can I hedge my bets? How can I make this transition to a new way of practicing? And there is this strong window of opportunity where the federal government is, for the moment, willing to help. New programs, new rewards.
The word change is coming.
Change is coming.
On a personal note, perhaps you could share with our viewers what it is that led you to health policy in the first place, but perhaps even earlier to medical school to begin with.
Well, it's an interesting story. So I grew up, with a very famous lawyer father who cast a long shadow. Wrote a book called Getting to Yes that we all need to read because it turns out to be pretty useful. But I had to run away from him for a long time. Didn't know what I would do. In college, I majored in mountaineering. Actually not possible. So I had to minor in East Asian studies. And I still was completely unsure what I would do with my life. So after graduating, I decided to drive an ambulance in Somerville, Massachusetts, 5 miles from where I'd grown up. And kids in Somerville were dying of things that my classmates didn't get. Asthma, juvenile onset diabetes. A couple had juvenile onset diabetes in my class in my private school, but no one was dying of it, and they were in Somerville. And I saw how poor the care was. And so I thought, gosh, I'm enjoying being on the ambulance. It's kind of exciting to do this clinical work, and it's not in law. And I knew we had an opportunity to make a difference through policy if we could just get people to pay attention to taking care, helping the system change so that doctors could be more effective in their practice. So I do have to pinch myself a little bit that 30 years later, not only did I have a chance to have 25 years of wonderful clinical practice, but now that I get to be involved in health policy as well, there's an awful lot of luck.
Well, you are making a difference. Thank you very much.
Thank you.
On this note, sincere thanks to Dr. Fisher and to you, our viewers, for joining Medscape One-on-One. Until next time, I am Elliott Adashi.